Very good morning. On the behalf of DAMS family, I, Dr. Deepak Arora, will welcome all the students on this auspicious day when we are connected with more than 60 centers all over the country. I would appreciate the vision of our director, Dr. Sumer Sethi, unbeatable vision. I will just share few moments. 2 years back, Dr. Sumer, when we started this concept of satellite-based coaching, he promised me that within next 2 years, we will be connected with the whole of the country. And that day has come when we are giving this special session to the whole of the country. Again, I will appreciate my whole working staff, technical staff who are working 24/7 for the last 1 month to make this day possible. Clear? Again, coming on this, I am from a very small town of Punjab, and today I feel very proud that we are giving best possible medical education to every Punjab medico. We are giving these sessions starting from Amritsar to the Pondicherry, all over the country. We are conducting this session today. Each and every student will enjoy these 3 days, and at the end of 3 days, you will feel, yes, you will be proud to feel a part and parcel of this DAMS family. So we start from the session of ENT. I will be showing you the slides. I will try to cover all the one-liner MCQs. Within the next 2 hours, I will try to compile the whole ENT, whole basic MCQs which are expected in your upcoming All India examination. So we start now. Very best of luck for the next 3 days. Yes, start. The first slide. This slide is a classical slide of Prusek space. Can you appreciate every center connected now? Now, this slide is a classical slide of Prusek space. What is Prusek space? Cholestroma, unsafe ear. Cholestroma, unsafe ear. The most common site of cholestroma formation is your Prusek space. So first important basic MCQ, the most common site of your unsafe ear is your Prusek space. Can you appreciate the arrow? Now I'm just showing you the arrow. This space is known as Prusek space, most common site for cholestroma formation. Now MCQ, what we are expecting from this Prusek space, how is the spread of infection, how the spread of cholestroma. So my book says 3 possibilities are there. Either the cholestroma will come into anterior epitympanum, or it will come into mesotympanum, or it will come into posterior epitympanum. Rohtak students, please concentrate. I will spell each and every point. Prusek space is the most common site of cholestroma. From this area, 3 possibilities can be there. It can come to anterior epitympanum, mesotympanum, and posterior epitympanum. So question will be, cholestroma from the Prusek space spread to anterior epitympanum. It spread to anterior epitympanum via anterior pouch. There is one, we have to just remember 2 pouches. One is pouch, anterior pouch, posterior pouch of Trollesch. Anterior pouch of Trollesch, it spread to anterior epitympanum. Posterior pouch of Trollesch, it spread to mesotympanum. Very sincere advice to everybody. Just write the MCQ, no need of writing each and every statement. Most common site, Prusek space, spread to anterior epitympanum via anterior pouch of Trollesch, posterior pouch of Trollesch to mesotympanum. So question is, how it spread to posterior epitympanum? Posterior epitympanum, it spread via superior incidal space. It spread via superior incidal space. So I am expecting 4 MCQs. Most common site, Prusek space, anterior epitympanum via anterior pouch, posterior epitympanum via superior incidal space, and mesotympanum, it is via posterior pouch of Trollesch. Don't get confused on this one. Clear? So first slide is over. 4 MCQs expected. Coming on the next slide, study the following slide. When you see this slide, One query, whether this is your ENT MCQ or this is forensic MCQ. Yeah, it may be a forensic MCQ. Study the following image. Which type of snake is it? Yes, it seems to be a like of snake, type of snake. No, it is not a type of snake. This is a otoscopic image of tympanic membrane. This is your otoscopic image of tympanic membrane. Concentrate. If examiner show you this image, he want to show you the keratin deposits. Can you appreciate small blackish areas? That is keratin deposits. So concentrate on this slide. And just remember which dye we are using. We are using 1% osmium tetraoxide. Everybody should write. This is which dye has been used on the tympanic membrane. We have used 1% osmium tetraoxide. 1% osmium tetraoxide. Why we are using this dye? We are using this dye to appreciate the keratin deposits. I want to appreciate the keratin deposits on the tympanic membrane via which dye? Osmium tetraoxide. What is the percentage? Your DNB people are more interested in asking the number MCQ. So it is 1% osmium tetraoxide. Clear? This is the second slide. Concentrate on the third slide. Most expected MCQ for your upcoming All India examination. 2 years back, your AIMS people, PGI people, they asked one MCQ. MCQ was pseudosulcus. What is pseudosulcus? Just concentrate on this slide. I will again come back to this slide. Just concentrate. We have to concentrate. What is true sulcus? So we have to discuss what is true sulcus. True sulcus is your mucosal fold. This is your mucosal fold on the vocal cord. This is a mucosal fold on the vocal cord. This is a normal finding. Always remember, this is a normal finding. This is a normal finding. True sulcus. Now question is, what is pseudosulcus? Always remember, pseudosulcus is your subglottic edema. It is your subglottic edema. Take my word, when this MCQ appeared in your All India AIMS examination, this MCQ was taken from this image, because this word is not mentioned anywhere except this image. So pseudosulcus is your subglottic edema, is a hallmark feature of gastric reflux. So what we are expecting now, which are the 4 hallmark features? Examiner can ask you any other MCQ apart from pseudosulcus. So you should remember, what are the 4 one-liner MCQs? The one-liner MCQs of gastric esophageal reflux disease, which are the hallmark feature? The first is your pseudosulcus. Second is vocal cord edema. Vocal cord edema. Always remember, it is vocal cord edema. Common sense, if the vocal cord will be edematous, if there will be edema on the vocal cord, what will be the status of glottic area? Do you remember in anatomy I taught you the other name of glottic is ventricle. So the vocal cord edema, the ventricle will be big or small? It will be small. Obliteration, ventricular obliteration, glottic obliteration, ventricle obliteration. And the 4th MCQ, which I am expecting for your next All India examination, examiner can ask you PCH, posterior commissure hypertrophy. So always remember, posterior commissure hypertrophy. Hypertrophy is a hallmark feature of gastric reflux. These are the 4 hallmark feature of my gastric reflux. This one MCQ can be there. Expected pseudosulcus or posterior commissure hypertrophy. Clear? This completes our 3rd slide. Now, the next slide. Yeah. On this slide, I am showing you the four options of gastric reflux. One is subglottic edema, one is vocal fold edema, one is ventricular obliteration, one is posterior commissure hypertrophy. Clear? Can you appreciate? I hope every student must be appreciating these four hallmark feature of gastric reflux. Now we concentrate the next slide. This is a slide for the incision on the tympanic membrane. Can you appreciate? This is a incision on the tympanic membrane. Any student who can tell me which incision is it? Anybody? Yes? Which incision I am showing you? Belgaum students, South students, which incision I am showing you? This is a Rosen incision, R-O-S-E-N, R-O-S-E-N. I will show you three type of incision, then I will teach you the MCQs. So concentrate, just focus on this slide. This is a Rosen incision, R-O-S-E-N. This is your Lempert incision. This is your Lempert incision, L-E-M-P-E-R-T. This is your Lempert incision. This is your Rosen incision. Try to compare. This one is your Rosen incision. This one is your Lempert incision. Lempert incision is along the above the tragus. If you keep your finger just above the tragus, it is your Lempert incision. The third incision which I want to show you is your post-oral incision, behind pinna. Behind pinna is your post-oral incision. So just draw three basic incisions, then I will coming on the take note. So I want to discuss you three basic MCQs on the incision side. The first one, is your on tympanic membrane, that is Rosen incision. One is your on tragus, this is your helix, this is your tragus. I am giving a incision on the above tragus, incisura terminalis. This is known as Lempert incision. And the last is behind tympanic membrane. The last is behind tympanic membrane. This is my tympanic membrane. So I am giving the incision behind tympanic membrane, which is known by the name of Wild incision. Rosen incision, Lempert incision and Wild incision. Rosen is used for stapes surgery. Stapes surgery, where we are doing stapes surgery? Otosclerosis, stapedectomy, stapedotomy. So Rosen incision is used for stapes surgery. Lempert incision is known as end oral incision. End oral incision. End oral incision. While behind tympanic membrane, we call it as post oral incision. Post oral incision. Rosen incision we are giving on tympanic membrane, so we call it as transcanal incision. The other name which examiner will ask you, transcanal incision. This is used for stapes, while Lempert and Wild oral, they are used for middle ear and mastoid surgery. They are used for middle ear and mastoid surgery. Clear? So these are three type of incision everybody should write. Rosen for stapes, Lempert for end oral and Wild for post oral incision. Rosen incision is used for stapes surgery. Which stapes surgeries are there? Otosclerosis, we are having two options, stapedectomy and stapedotomy. According to the new concept, according to the latest concept, what your AIMS department is saying, stapedotomy is better than stapedectomy. Always remember this point. If examiner give you both the choices, treatment of choice for otosclerosis, the better to go for stapedotomy is a better option than stapedectomy. Remember this point? Clear? Again, I will show you the slides. Coming back to the topic. This one is your post-oral incision, which I am showing you. Again, the students who have just missed out, you can write this one. This is your post-oral incision. This is a Lambert incision. Lambert incision. This is your Rosen incision. R-O-S-E-N. Rosen incision. Concentrate on this slide. If examiners show you this slide, this is your keloid. Multiple small keloids on the pinna. This slide is a classical slide for keloids. What is the treatment? What we used to do 5 years, 6 years back, we used to give incision, we used to remove it, we used to inject some medicine in this keloid, and we used to do pressure dressing. What is the new concept? The latest concept of keloid is external radiotherapy. Your book says short external radiotherapy is beneficial, is a treatment of choice for keloid. So latest concept, external radiotherapy is the treatment of choice for keloid. Concentrate this slide. Just 1 second. This slide is a slide of tympanosclerosis. This slide is a slide of tympanosclerosis, a whitish patch on the tympanic membrane. Just remember, Bilaspur student, absolutely right. It is like chalky whitish deposit on the tympanic membrane. Tympanosclerosis. Write 3 MCQs. Tympanic membrane, hypomobile. Capital letters, tympanic membrane will be hypomobile. On tympanometry, which graph will be seen? AS. I will teach you what is AS graph, what is AD graph, but Bilaspur students, absolutely right, it is AS graph. Tympanic membrane will be hypomobile and it will be AS graph. Tympanosclerosis. This is a sclerotic patch on tympanic membrane. No other expected MCQ on this slide. Concentrate on this slide. This is a classical slide of serous otitis media. This is a classical slide of ASOM, acute suppurative otitis media. I have to compare this slide with serous otitis media. Just remember, if congestion present on this tympanic membrane, can you appreciate? White, reddish, small lines are seen. These reddish small lines are images of your blood vessel. So this is your acute inflammation. Acute suppurative otitis media. Very favorite MCQ of your AIMS. All of the following statement are true statement regarding serous otitis media. Glue ear. In glue ear, they will give the first choice, congested tympanic membrane. No, never. Congested tympanic membrane is a feature of ASOM, acute suppurative otitis media. Last DNB, last All India, which MCQ was there? Can you appreciate? If you just concentrate on this slide, multiple small reddish line like a cartwheel appearance of the tympanic membrane. So just remember, cartwheel appearance of the tympanic membrane is seen in ASOM, acute suppurative otitis media. Cartwheel appearance of the tympanic membrane is a hallmark feature of ASOM. What is the treatment of choice? Just remember, treatment of choice for ASOM, acute suppurative otitis media, will be myringotomy. ASOM, myringotomy, acute suppurative otitis media. I will give an incision on the tympanic membrane. Will you give a small incision or you will give a big incision? Always remember, ASOM, acute suppurative otitis media, I will give a circumferential incision. No, dear students, not small, it will be big. Circumferential incision. Always remember circumferential incision. SOM, serous otitis media, the glue ear, I will go for small incision. Clear? ASOM, big circumferential incision. While case of ASOM, it will be small incision. So I will give you some difference between SOM and ASOM as far my MCQs are concerned. Always remember, SOM, that is glue ear, against ASOM, acute suppurative otitis media. I'm not going for teaching the whole topic. Basic MCQs. No congestion. Congestion present. Always remember, congestion is a hallmark feature of ASOM. Serous otitis media, we are giving a small incision on the tympanic membrane. Which part of the tympanic membrane? Very favorite MCQ of DNB. Anterior-inferior. Always remember, it is anterior-inferior part of the tympanic membrane. ASOM, I am giving a circumferential incision. In ASOM, I am giving a circumferential incision. Always remember, SOM, serous otitis media, I will insert a grommet. ASOM, I will never insert a grommet. Grommet is a foreign body. I will never insert a foreign body in infected cases. Grommet is inserted in glue ear, not in ASOM. So these are the three expected MCQs. No congestion is there, anterior-inferior and grommet insertion. Along with the grommet, I always remove adenoid. Whenever a child comes to me in my private setup, I always go for myringotomy with grommet insertion with adenoidectomy. Students who are going for AIMS, this MCQ can be repeated. Treatment of choice for serous otitis media. Treatment of choice for serous otitis media is myringotomy with grommet insertion with ASOM. Are you getting the concept? Now I will show you the slide of grommet insertion. Always try to identify a small ventilatory tube. If a small ventilatory tube is there on the tympanic membrane. Now concentrate. This is a small ventilatory tube. Sorry. A small ventilatory tube on tympanic membrane. Just 1 second. Yeah. Now, this is a small grommet inserted. Most expected MCQ, every student should write in capital letter, last all India. After how many months you will go for grommet insertion? Patient comes to me. I go for myringotomy. Patient again come to me. I again go for myringotomy. But I will wait for how many months? I will wait for 3 months. Always remember. I will wait for 3 months. If patient is not responding within 12 weeks, 12 weeks is equal to 3 months. Patient not responding up to 3 months, I will insert grommet. Agartala students, absolutely right. This is 3 months. Answer, just remember expected MCQs. 2 MCQs were there in last All India, answer to which were 3 months. 1 MCQ was after how many months you will insert grommet. Answer was 3 months. What is the definition of chronic sinusitis? Answer was 3 months, more than 3 months. So 3 months will give you 2 MCQs in All India examination. One is grommet is inserted after 3 months. And second one is here, chronic sinusitis. Definition of chronic sinusitis is here, sinusitis more than 3 months. Clear? Now, as far grommet is concerned, again one more MCQ is expected. You write which are the compound we can use for grommet formation. If I want to, grommet is made up of, examiner can ask you. So write a mnemonic SGPT. SGPT square. Clear? So S for silicon, the first important, you can say, material with which we make grommet is your silicon. SG, G for gold, one is silicon, second is your gold. P for plastic, P for plastic, it is fluoroplastic. S for silicon, G for gold, P for plastic. Which plastic? Fluoroplastic. Fluoroplastic. Last T square, we have to learn 2T. One is Teflon, one is titanium. One is Teflon, one is titanium. So we will learn a mnemonic of SGPT square. S for silicon, G for gold, P for plastic. Which plastic? Fluoroplastic. T square, T for titanium, T for Teflon. So MCQ will be, study the following image. The whitish structure is made up of all of the following except. So you have to remember these are the 5 different compounds with which I can make my grommet. Clear? Any queries you can ask me simultaneously, not an issue. Few centers are very new to us today. We have added, I think, 5 or 6 new centers today just for the sake of this DVT session, like our Pondicherry, Chennai, Amritsar, Patiala. So these students, I think you will not be comfortable with asking the question. Other all students are connected with us for a last 1 year, so you can just ask any question from these centers by just typing. You just type, we will get the, like Mysore students are asking, what is the preferred site for grommet insertion? Grommet insertion literature. So the new centers which are connected, just be adapted. You can ask any query. It is a, you can say, discussion going from both sides. So Mysore students, what is the preferred site? My book says it is better to insert grommet on the posterior inferior, but clinically always go for anterior inferior. I always go for anterior inferior insertion. Jammu students, among this, what is best? There is no question what is best. The question is which is most commonly used. We most commonly use Teflon component. Is, you can say, for cost effectiveness we use Teflon. Clear? Next slide. This slide is a slide of retracted pocket formation. Retraction pocket formation. I always teach in my lectures the basic funda. On otoscopic examination, if examiners show you any slide, Nagpur students, yes, cartwheel appearance present in reference to ASM, yes. Retraction pocket, Belgaum student, yaar, just wait for 5 minutes, I will teach you every point. Retraction pocket, how to identify retraction? Just remember, if examiner show you on online examination in front of your computer, if only malleus is visible, it is normal tympanic membrane. I think my students must have written this point in class. Only malleus visible, normal. More than malleus visible, it is a retraction. Can you appreciate this slide? On this slide, malleus visible, incus visible, malleus visible, incus visible, step is visible. Some part of the step is. This is a retraction pocket formation. So what is the question? Which is the MCQ? The MCQ is, what is the most common cause of any pathology in the middle ear? Always remember, eustachian tube dysfunction. Eustachian tube dysfunction is the most common cause of any pathology in the middle ear. So if examiner asks you the most common cause of any pathology in the middle ear, examiner will give you 2 options. Either he will give you eustachian tube dysfunction, or because of this eustachian tube dysfunction, the eustachian tube create the pressure. When it create the pressure, there is a retraction pocket formation. So if I am the examiner, I will ask you, most common cause of pathology in the middle ear, first choice, retraction pocket formation. That is the best choice. So examiner can either give you eustachian tube dysfunction or can give you retraction pocket formation. DNB people, they can give you both the choices. Better to go with retraction pocket because it is a result of eustachian tube. So what is the main cause? Go for retraction pocket formation. Or other way around, examiner will ask you, what is the most accepted hypothesis for cholestoma formation? Cholestoma formation, there are multiple hypotheses. metaplasia, it may be invasion, it may be retraction. So most accepted hypothesis for cholestoma formation is your retraction pocket formation theory. Retraction pocket formation theory is the most accepted hypothesis for cholestoma formation. Eustachian tube dysfunction, 3 MCQs expected. Last All India, what is the length of Eustachian tube? Mentioned in every books, it is 36 mm. Length of the Eustachian tube is 36 mm, but the MCQ was in last All India. What is the length of the Eustachian tube in a child, बच्चों में, in pediatric age group? What is the length? Just half. 36 divided by 2, 18 mm. Just remember, 18 mm is the length of Eustachian tube in pediatric population. Last DNB 1 MCQ was there. You can say the most cheap MCQ in the last DNB in ENT. The MCQ not expected. I don't know who had made this MCQ. MCQ was, listen the MCQ. When you listen this MCQ ना ऐसा मन करता है कि जिसने बनाया उसको लेके आओ. Bring the examiner who have made this MCQ. MCQ was, during Valsalva, how much pressure is required to open Eustachian tube? Most irrelevant MCQ related with the Eustachian tube. You have to just remember it is 33 millimeter of mercury. 33 millimeter of mercury is required to open Eustachian tube during Valsalva. This is important MCQ. You should remember. Concentrate on this slide. When you focus this slide, you will appreciate there is a perforation. Yes, there is a small perforation in the lower part. There is a big perforation in the attic area. Attic is the upper part. There is a big perforation in the pars flaccida upper part with white necrotic tissue. White necrotic tissue. So this is a classical slide. This is a classical slide of unsafe ear. Cholestoma. What is the management of cholestoma? Just remember 2 MCQs. If examiner asks you unsafe ear, what is the management of unsafe ear? Answer is MRM, modified radical mastectomy. Canal wall up MRM. Canal wall up MRM. And if examiner give you unsafe ear with any complication, if any complication is mentioned in my MCQ, go for canal wall down MRM. Just basic funda you should remember. Only unsafe ear, canal wall up MRM. Any complication mentioned, canal wall down MRM. Down canal wall. Which wall? Posterior wall. I am talking about posterior wall. No need of going in the detail. We want just MCQs. Now complication. On Facebook, exclusive club, every day I'm getting this query. Many students are asking this query. No need of getting confused. Most common complication extracranial is mastoiditis. Always remember, just 1 minute on the complication. Most common complication extracranial. Always mastoiditis. Clear? Overall, most common mastoiditis. Intracranial, the most common is your meningitis. Very controversial MCQ. Meningitis, again brain abscess. After every 6 months, this answer is changed because your AIMS department, sometimes they say meningitis, sometimes they say brain abscess. Latest, meningitis is more common than brain abscess. Which lobe is most commonly involved? Temporal lobe is most commonly involved. Always remember, intracranial, temporal lobe is most commonly involved. Which part of the facial nerve is damaged in unsafe ear? I am talking about unsafe ear. I am talking about unsafe ear. Tympanic part, expected MCQ. Which part of the facial nerve is most commonly damaged in unsafe ear? It is tympanic part. Now examiner asks you one important complication. Lateral sinus thrombophlebitis. Lateral sinus thrombophlebitis. What is lateral sinus thrombophlebitis? Expected, very expected topic which can be there in your All India examination. Lateral sinus thrombophlebitis. Thrombus formation in a sinus. Now concentrate. The MCQ is, with the invention of IV antibiotics, which of the following complication has been reduced drastically? Common sense. 1 century back, when the IV antibiotics were invented, which complication reduced drastically? My common sense say IV, intravenous. If I'm giving antibiotics, what is sinus? Sinus is something formed by combination of multiple veins. So maximum concentration of the drug will be in venous compartment. So this was the complication which reduced drastically after IV antibiotics. Always remember this point. Now at this point, if I am the examiner, I will ask you 2 MCQs. Before IV antibiotics, pre-era, post-era. These are the 2 MCQs. Before IV antibiotics, which was the most common bacteria for lateral sinus thrombophlebitis? Streptococcus. Just remember, pre-antibiotics era, it was Streptococcus. Post-antibiotics era, it was gram-negative bacteria. Gram-negative bacteria, not given in choice, go for E. coli. So these are 3 MCQs which we are expecting for your All India examination. With the invention of IV antibiotics, which complication reduced drastically? It was lateral sinus thrombophlebitis. Pre-antibiotics era, it was Streptococcus. Post, it was gram-negative or E. coli. Now few important signs you should remember. The first, which is a type of fever in lateral sinus thrombophlebitis, it is hectic fever or picket fence fever. Picket fence fever. The second sign you have to remember, Grisinger sign. One is your Crowback sign. Crowback sign. One is your Tauber-Ayer sign. One is your Delta sign. These are the 5 signs on which I am expecting the MCQ in your All India. Hectic picket fence fever is a spiky fever. What is Grisinger sign? Big mastoid veins. Big mastoid veins is Grisinger sign. What is Crowback sign? Big retinal veins. Big retinal veins in a patient of lateral sinus thrombophlebitis is your Crowback sign. What is Tauber-Ayer? You take your finger, push your jugular. If you push your jugular, your intracranial tension increase. But because there is a communication. But in this patient, there is a thrombus. No increase in intracranial pressure. No change in intracranial tension on pressing jugular. What is Delta sign? Is a CT MRI finding. On CT MRI, the thrombus appears like a delta. Thrombus appears like a delta. Clear? So these are the 5 signs you should be aware of for lateral sinus thrombophlebitis. What is a rare complication? Always remember, aortic hydrocephalus. Aortic hydrocephalus is a rare complication. Aortic hydrocephalus is a rare complication of unsafe ear. Clear? This completes our basic MCQs on the complication segment. Now concentrate this slide. This is a slide for congenital cholestoma. Congenital cholestoma. White, reddish, white, brilliant granules. Can you appreciate? Congenital cholestoma. white brilliant granules behind tympanic membrane. 4 important sites of congenital cholestoma. Everybody should write the 4 important sites for congenital cholestoma. Middle ear, yes. Mastoid, yes. Petrous apex and CP angle, cerebropontine angle. The 4 important sites for this slide. Study the following slide. This slide can be possible at all of the following sites except. So this is possible. Congenital focus of the cholestoma is possible in middle ear, mastoid, petrous apex and CP angle, cerebropontine angle. Out of these 4 sites, the most common site is middle ear. Just remember, out of 4 sites, middle ear, mastoid, petrous apex and CP angle, the middle ear is the most common site. Clear? Congenital cholestoma. Cholestoma of 3 types. Congenital, that is present in a newborn. If cholestoma is a sequelae of retraction pocket leading to cholestoma, primary cholestoma, perforation, infection leading to cholestoma, secondary cholestoma. Just remember, one is congenital, one is retraction pocket. As a result of retraction pocket, that is primary. As a result of perforation, infection, secondary. Now, everybody, I think every student is comfortable with this one. What is congenital? What is primary? Primary as a result of retraction. Secondary as a result of infection. I'm operating the patient. I'm doing tympanoplasty. Imagination. I'm operating the patient. I'm touching the middle ear. Whenever I touch the middle ear with my instrument, this is a stimulus for the middle ear. So my book says, whenever you touch middle ear after tympanoplasty. What is tympanoplasty? Tympanoplasty is a management of safe ear. So safe ear, whenever I repair the middle ear, I give a stimulus to the middle ear, cholestoma can be there. So cholestoma after tympanoplasty can be a complication. Yes, it can be a complication known as tertiary cholestoma. So what is tertiary? Tertiary cholestoma is after, as a result of any surgical intervention. So congenital in a newborn, primary retraction pocket. So there is a different skill of attempting MCQ. No need of writing the whole statement. Just you should write congenital is equal to newborn. Primary is equal to retraction. Secondary is equal to infection. Surgery is equal to tertiary. That's it. It will give you one MCQ. Concentrate on this slide. If examiner want to give a orthoscopic image, he will give you this image. This is a traumatic perforation. 75% of tympanic membrane is normal. On one side, blood clot is there. History of slap. In the MCQ, history of trauma will be there. Traumatic perforation. Management of choice. Conservative. Wait and watch. Conservative management. Wait and watch. 3 or 4 conditions in which I will go for wait and watch. These are always expected MCQs. Make a box, write wait and watch. Wait and watch policy. 3 or 4 MCQs. One is traumatic for perforation. Traumatic perforation, I will go for wait and watch. CSF rhinorrhea. CSF rhinorrhea, I will go for wait and watch. Laryngomalacia. Laryngomalacia, the most common congenital abnormality of larynx. Laryngomalacia, wait and watch. CSF rhinorrhea, wait and watch. Traumatic perforation, wait and watch. Leukoplakia of the larynx. I will show you within just half an hour. I will show you the slide of leukoplakia of the larynx. Wait and watch. Wait and watch is the treatment of these 3-4 conditions. 99% they will pick one. Either traumatic, CSF rhinorrhea, or leukoplakia, or here laryngomalacia. These are the conditions where we go for wait and watch. Can you appreciate? Now Belgaum students, you are asking something. Now concentrate. This is your blood clot with perforation, but you appreciate this slide. When you appreciate this slide, on this tympanic membrane there is a blood clot behind tympanic membrane. Can you appreciate? There is a blood clot behind tympanic membrane. So Belgaum students were asking me regarding hemotympanum. This is hemotympanum. Tympanic membrane, behind tympanic membrane there is a blood clot. 99% expected MCQ. Study the following slide. This slide is associated with which sign? Belgaum students, yes, now you reply. This slide is associated with sign. कौन सा sign दिखेगा? We will get which sign in this patient? Anybody from any center? Yes, my Patiala students. Which sign will be seen in this patient? Pune, very good. Battle sign. This is a patient of trauma, roadside accident. There is a skull fracture leading to hemotympanum, leading with ecchymosis behind the pinna. The MCQ in the last DNB, ecchymosis behind pinna is battle sign. Just below pinna you will get some ecchymosis, reddish spot is battle sign. Manipal students, absolutely right. This is your, this slide is associated with hemotympanum, is associated with battle sign. Any student, concentrate on the given slide. Study the slide. Which sign is being shown? Which sign I am showing you? This is your rising sun sign. This is a classical image of rising sun sign. Is a hallmark feature of glomus tumor. Is a hallmark. Rotak students, absolutely right. Is a hallmark feature of glomus tumor. What is glomus tumor? Most common vascular tumor of middle ear. Most common vascular tumor of the middle ear. 2 or 3 signs are there. Glomus sign should be on your tips. If I increase the pressure, on this tympanic membrane will blanch. Blanching known as brown sign. Rising sun sign, brown sign. Rising sun sign is a reddish tympanic membrane. Brown sign is a blanching. One last important sign everybody should write, flap sign. P-H-E-L-P. P-H-E-L-P, flap sign. What is flap sign? Flap sign is loss of, capital letters, loss of bony partition. Flap sign is loss of bony partition between carotid and jugular vein. Carotid and jugular vein, if you take a normal CT scan examination in a normal human being, there is a bony partition. But if there is a glomus tumor, it will damage the bony partition, and that damage is known as flap sign. P-H-E-L-P, flap sign. Concentrate on this slide. This slide is a, if I show you the instrument, study the slide. Anybody who can tell me which instrument is there on your left side? Like you are sitting in the classroom. On the left side, very good. Pune students, on the left side is your Barani box, Barani apparatus. On the right side is PTA, pure tone audiometer. So on one side is Barani, on the other side is your PTA, pure tone audiometer. PTA, this basic slide can be shown to you. So we'll discuss few basic one-liner MCQs for this slide. Barani box. Again, I will suggest you, sir, every student should write without taking care of these slides. We will give you all these slides on your DAMS cloud. You can get all the slide. What is very humble request to everybody, just go on writing. When you go home after 3 days, when you open your cloud, you will get each and every slide. You will correlate all the points. So at this point, your job, your duty is to write each and every point. Barani box is equal to masking, used for masking. It give a non-specific sound. It give a non-specific sound, which is known as white sound. And we give this white sound to which ear? The ear which we want to evaluate, or ear which we are not interested. It is used for unwanted ear. Unwanted ear. PTA, pure tone audiometer, is used for wanted ear, the ear I want to evaluate. Which frequencies PTA can give? Always remember 250 to 8000 Hertz expected MCQ. What is the limit of PTA? Limit of PTA is 250 Hertz to 8000 Hertz. What is the limit of high frequency audiometer, HFA? What is the limit of HFA? Always remember HFA, high frequency audiometer, can give 8,000 to 20,000 hertz. Clear? Pure tone audiometer give 250 to 8,000 and HFA give 8,000 to 20,000. HFA is used for ototoxic drugs. याद रखेंगे, always remember this point. It is used for ototoxic drugs. HFA is used for ototoxic drugs. PTA, pure tone audiometer. 8 important findings should be on your tips. The first important finding: airborne gap with mild deafness is conductive deafness. Always remember, conductive deafness. No airborne gap with severe deafness is sensory deafness. No airborne gap with very severe, that is profound deafness, is equal to neural deafness. Neural deafness. No airborne gap with no deafness is equal to normal human being. These are the 4 one-liner MCQs you should be aware of. Maximum hearing loss at 2000 hertz is equal to Carhart notch, is equal to otosclerosis. Maximum hearing loss at 2000 hertz is known as Carhart notch, which is otosclerosis. Maximum at 4000 hertz is known as noise induced hearing loss. Noise induced hearing loss, which is known as Boiler's notch. Always remember, it is known as Boiler's notch, or it is known as acoustic dip. So 3 MCQs. Maximum hearing loss. Maximum hearing loss at 4000 is noise induced trauma, or it is Boiler's notch, or it is acoustic dip. Clear? The next MCQ you should be aware of. What is U-shape audiogram? Most expected MCQ. U-shape audiogram or basin audiogram or trough, TROUGF, trough audiogram. Any student? Can you reply this one? U-shape or basin or trough. These are the hallmark feature of. Yes, Chennai students, what is the reply of this one? Pune, absolutely right. Congenital deafness is a hallmark feature of congenital deafness. External. Congenital deafness is a hallmark feature of congenital deafness. Clear? Sorry. Now, I always criticize such MCQs, but your DNB people are asking again and again, what are the symbol we are using for audiometry? Which symbol we are using for audiometry? So please copy fast. Air conduction, right side is being used by a circle, by a cross on the left side. If air conduction is unmasked, if air conduction is masked, we use a triangle for right ear, we use a square for left ear. The same bone conduction, unmasked, bone conduction, mask. No response is coming, we use arrows. Agartala students, I will just try 1 second. Yeah, Agartala students, now you are getting. Copy the symbol fast because last DNB they have asked these symbols. S symbol S is used for non-ear specific sound field. S is used for non-ear specific. Clear? Copied? This is a classical airborne gap. This is a classical airborne gap. Can you appreciate? The air conduction more than 20 and bone conduction less than 25. Air conduction more than 25. This is a classical image of Carhart notch. This is a classical image of Carhart notch. Maximum hearing loss at 2000 hertz. Maximum hearing loss at 2000 hertz. This is a classical slide for sensory neural deafness. Sensory neural deafness. Can you appreciate? No airborne gap is seen, and both air conduction and bone conduction are in the range of 70-80 decibel hearing loss. Clear? So this is a classical image of sensory neural hearing loss. This is often frequently I have shown you this slide on my exclusive club. You just study this given slide. This is a classical slide of perichondritis, inflammation of pinna. This is a classical slide of perichondritis. Which bacteria is responsible? Write a formula. Write 2 or 3 basic formulas. Malignant otitis externa. Write capital letters. Malignant otitis externa. This is a classical slide of perichondritis. Or what we will do, you just write this, just see this slide. Now you compare this slide with this slide. If you compare this slide, if you compare 3 slides, now just concentrate. Now concentrate these slides. The first slide is your, dekho, can you appreciate? Just 1 second, I will show you. Can you appreciate? These small reddish nodules are there. These are known as These are known as apple jelly nodule. These are known as apple jelly nodule. Now just concentrate on this slide. Just appreciate this slide. This is your blackish discoloration of the pinna. This is a classical slide of malignant otitis externa. And if there is a generalized reddish red pinna with no blackish discoloration, it is perichondritis. So these are 3 slides which I want to concentrate. The first slide is your apple jelly nodule, that is a feature of lupus, right? Derma slide. Malignant otitis externa, then is perichondritis. These are the 3 slides. Now we will write few MCQs. Malignant otitis externa is equal to generalized otitis externa is equal to perichondritis. Malignant otitis externa is equal to generalized otitis externa is equal to perichondritis is equal to pseudomonas. The first important formula. Second formula we will write 55 minus 10 is equal to 45. The second formula which we will write 55 minus 10 is equal to 45. 55 is the angle of tympanic membrane with the horizontal plane. The 3 one-liner MCQs we should write. The angle of the tympanic membrane with the horizontal line is 55. What is the 10? 10 degree is the angle of eustachian tube in pediatric population. Angle of eustachian tube in pediatric population is 10 degree. What is 45 degree? Angle of eustachian tube in adult. So these are 3 MCQs, should be on your tips. 55 minus 10 is equal to 45. 55 is your horizontal angle, tympanic membrane angle, and 10 and 45 are the angle of eustachian tube with your pediatric age group and adult age group. Clear? Malignant otitis externa. The other name, always remember, is known as osteomyelitis of the skull base. Is known as osteomyelitis of the skull base. Word diabetic should be there. Word diabetic should be there in malignant otitis externa. Pseudomonas is the most common bacteria. Treatment of choice is a medical treatment. Always remember, treatment of choice is the medical treatment. Which medicine, which is a drug of choice? Third generation cephalosporin. Always remember, third generation cephalosporin. Not given in the choice, go for penicillin group. Not given in the choice, go for ciproflox. This is a controversial MCQ. Please write carefully. We have confirmed from our AIMS faculty of pharma. The pharma faculty is saying third generation cephalosporin, best choice, followed by penicillin, second choice. Ciproflox is the third choice. Clear? What is the investigation of choice? We have to remember 2 scan, technetium 99 scan, gallium scan. Technetium 99 scan is used for diagnosis. Gallium scan is used for prognosis. Technetium 99 scan is used for diagnosis. Gallium scan is used for prognosis. Treatment of choice is medical treatment. Or what surgery? If we want to do surgery, which surgery we are doing? Any student? Yes, any student from South? Which surgery we are doing? I have taught you in the lectures. Very good. Belgaum students, in the last week when I was teaching you in satellite coaching, satellite surgery, which surgery? Debridement. Only debridement is done. We are not doing any big surgery. Examiner will give you big surgeries, but we are doing only debridement. Just remember, we are doing only debridement. Debridement is the surgery of choice. This is a classical slide of, concentrate on this, just 1 second. This is a classical slide of bat ear. Can you appreciate? No anti-helix is visible, only helix is visible. So this is bat ear. 2 MCQs which you should remember. One-liner basic MCQs. Pinna. The tragus comes from first brachial arch. Tragus comes from first brachial arch. Rest of pinna from second. Tragus come from first brachial arch. Rest of pinna from second. Lobule is the last structure to develop in intrauterine life. Lobule is the last structure to develop in intrauterine life. Pinna achieve the adult configuration. Pinna achieve the adult configuration by 6 years. Pinna achieve the adult configuration by 6 years. Therefore, no surgery should be done below 6 years. Therefore, no surgery should be done below 6 years. Inner ear, labyrinth, inner ear is the first sensory organ to develop in our body. Inner ear, labyrinth is the first structure to develop in our body. Tip of the mastoid. Mastoid tip develops by 2 years. Mastoid tip develops by 2 years. periphery of the tympanic membrane, periphery of the tympanic membrane is more mobile. Periphery of the tympanic membrane is more mobile. All these are one-liner MCQs which appeared in last 2 years DNB question bank. Periphery of the tympanic membrane more mobile. Which part of pinna is, on which part of the pinna the skin is loosely attached? So one is lateral surface, one is medial surface. It is loosely attached on medial surface. Pinna is loosely attached on medial surface. Concentrate this slide. This is a classical slide for tympanometry. I am comparing the pressure against the movement of the tympanic membrane. So capital letters, right? Which are the two units we are comparing? We are comparing pressure difference, pressure against movement of the tympanic membrane, pressure against normal, pressure against eustachian, pressure against movement of the tympanic membrane. This is tympanometry. So few one-liner MCQs. Just one second. Few one-liner MCQs on this tympanometry. Tympanometry is a part and parcel of impedance audiometry. So always remember few points. Impedance audiometry is an investigation of choice for conductive deafness. Impedance audiometry includes tympanometry with stapedial reflux. Now tympanometry, as far tympanometry is concerned, is an investigation of choice for conductive deafness. Conductive deafness, so we have to remember few MCQs. The graph are different type of graph on tympanometry are A is a normal graph, AS otosclerosis, tympanosclerosis, AD ossicular disruption, ossicular disruption, B is seen in perforated cases, C is a feature of eustachian tube dysfunction, flat is a feature of glue ear. So write all these one-liner MCQs. Normal graph is A. Normal graph is A. AS. AS is otosclerosis. AD is ossicular disruption. B is perforation. C is eustachian tube dysfunction. Flat is glue ear. According to few books, according to few Indian books, B tympanogram is equal to flat tympanogram. Just remember this point. According to few books, B tympanogram is flat tympanogram. Most common cause of any abnormality, is eustachian tube dysfunction. Therefore, most common abnormal graph is C graph. Most common abnormal graph is your C graph. Always remember this point. So these are the basic MCQs on impedance audiometry. Investigation of choice. One-liner MCQs you should always remember. Conductive deafness, investigation of choice, impedance audiometry. For sensory deafness, it is electrocochleography, and for neural deafness, it is BARA. For neural deafness, it is BARA. Conductive deafness, impedance audiometry. Sensory deafness, it is electrocochleography, and for neural deafness, it is your BARA. So this is a normal graph. This is a graph. Just have a memory. This is a alphabet A. This is a normal graph. If this is normal, what is this one? This one is AD graph. If this is normal, this one is AD graph. Is a feature of ossicular disruption. If this is AD, this is your AS graph. If this is AD, this is hypomobile graph. AS graph, otosclerosis. Now concentrate on this one. This slide is a classical slide of seagull speculum. This is a slide of seagull speculum. Dibrugarh students, in pregnancy, which graph is seen? There is no such MCQ. In pregnancy is a predisposing factor for autosclerosis. So if examiner asks you in pregnancy which of the following graph is expected, go for AS, because examiner is giving you a clue for the autosclerosis. Are you getting the concept, Dibrugarh students? Pregnancy, we will go for AS graph. After stapedectomy, JIPMER 2013, last year JIPMER people ask on MCQ. After stapedectomy, if I remove stapes, treatment of autosclerosis, after stapedectomy, the graph will be AD graph. Autosclerosis, AS graph. After surgery, AD graph. Always remember, Kochi students, absolutely right. It is AD graph. Clear? This is your seagull speculum. This is your seagull speculum. Just Dibrugarh student, just wait here. I will teach you each and every point. Have some patience here. This is a slide for seagull speculum. Seagull speculum we use for magnification. We use for giving some drug in the external auditory canal. But we never use for foreign body. Always remember, seagull speculum is never used for foreign body. Now concentrate on this slide. I will show you a few slides of larynx and I will come back again on ear. Just concentrate on this slide, on the simpler side. If we go on the simple, easy concept, this is a slide for preauricular sinus. Can you appreciate? A small opening in front of pinna. A small opening in front of pinna is there. Can you appreciate? This is preauricular sinus. This is your preauricular sinus. This is a abnormality of first brachial arch. Always remember, this is a abnormality of first brachial arch. This is a abnormality of first brachial arch. This is a abnormality of first brachial arch. Concentrate on this slide now. This is a slide for preauricular tags. Can you appreciate? There is few tags in front of pinna. These are preauricular tags, congenital abnormality of mainly first brachial arch. Why? I give you the common sense logic. Tragus comes from first brachial arch, rest of pinna from second brachial arch. Preauricular sinus, tags, they are always surrounding tragus. Therefore, this is a classical image for first brachial arch abnormality. Visible. This is preauricular tags. Now concentrate this slide. This slide is a Menet device. MENIETE. This slide is a Menet device. This slide is a classical image of Menet device. We are using for which disease? This is a treatment of choice for which disease? Meniere's. Yes, my students. In Meniere's, we are using PPT, positive pressure therapy. Positive pressure therapy. In Meniere's, we are using positive pressure therapy. Menet device is a external device. AIMS people, AIMS people have given one MCQ. Minute device is fitted on oval window. No, minute device is a external device. Is placed in the external auditory canal. This is used for Meniere's. This is a symptomatic treatment. As for Meniere's, what is the expected MCQ? Which of the following chromosome is associated with Meniere's? Always remember chromosome. Which chromosome is associated? Chromosome number 14. 1-4. 3 chromosomes are associated with Meniere's. One is chromosome number 14. One number is 6. My student, 14 more than 6 more than 12. Always learn this formula. It is 14 more than 6 more than 12 associated with Meniere's. Treatment of choice, surgical decompression. Study the following slide. This is a classical slide for electrocochleography. Can you appreciate? We are keeping the electrode. Expected MCQ. Study the following image. Is done for sensory loss, cochlear abnormality. Any problem in the cochlea, I will use electrocochleography. Where you are keeping the electrode, just concentrate, focus your eyes on the image. Electrode is kept on promontory. We keep the electrode on promontory. So this is a invasive investigation. We perforate the tympanic membrane, we go inside, we keep the electrode on the promontory. Invasive investigation. Electrocochleography, investigation of choice for sensory loss. Now concentrate this slide. What is this one? Anybody? What is this slide? This slide is for BERA, B-E-R-A, brainstem, evoke, response, audiometry. Yes, very good. Every sentence is replying. BERA, brainstem, evoke, response, audiometry. Hi sir, what is expected MCQ? Which MCQ will be there in your All India? Will fully confidently we can say this point. Which MCQ will be coming in your All India? Any student? Every day, every second student is asking this MCQ, which was the MCQ of last All India examination. This MCQ appeared in All India. This MCQ appeared, no, fifth wave appeared. My student, fifth wave appeared in AIMS examination. DNB and All India examination. The MCQ was, what was the earliest age for doing BERA? What is the earliest age for doing BERA? Most expected MCQ for next All India examination. Anybody? At what week we can do it? Our book says you can do BERA more than 27 weeks. In choice, answer was 28 weeks, 30 weeks, 32 weeks. So best choice was 28 weeks. Kolhapur student, absolutely right. Most expected MCQ. What is the earliest age for doing BERA? So it is 28 weeks. We can go for BERA. 28 weeks we can do BERA. This is, you can say, we have searched a lot for this MCQ. And one of the literatures say that after 26-27 weeks you can do BERA. So BERA is used after this. Please highlight right on the front page of your book. MCQ will be there in your All India AIMS examination. As far as screening procedure of choice is concerned, always remember OAE, auto acoustic emission. As for investigation of choice, newborn. I am talking about newborn. Screening procedure of choice, OAE. Investigation of choice, BERA. What is the latest guidelines of National Deafness Program? National Deafness Programs. What is the latest guideline? Latest guideline for National Deafness Program is you should do OAE on first day of life. Okay? On first day of life you should do OAE. If patient is not showing any signal, no signal is coming. On discharge of the newborn, do BERA. This is the latest guidelines from your AIMS department. OAE should be done on the first day of life. If patient is not showing any signal, means suspected newborn, no signal on OAE, we have to do BERA on the day of discharge. Clear? Now, write few basic MCQs on the treatment of choice. As for treatment part is concerned, again from this zone, MCQ will be there. For conductive deafness, I will go for hearing aids. For sensory deafness, I will go for cochlear implant. For neural deafness, I will go for brain stem implants. So these are 3 expected MCQs. For conductive deafness, I will go for hearing aids. Sensory deafness, I will go for cochlear implants. For neural deafness, I will go for brainstem implant. The most expected, the most crucial topic is your cochlear implants. So we are having 9 or 10 one-liner MCQs on cochlear implants. Please write fast in a fast mode. Cochlear implants. Lowest age of using cochlear implant till date is 1 year. Lowest age is 1 year. Is used for severe deafness. Postlingual candidate are the best candidates. Lowest age 14. Lowest age is 1 year. Severe deafness is indication. Postlingual are the best patients. Multi-channel electrode are the best electrodes. External device is formed by PMT, mnemonic PMT. External device is formed by PMT, processor, microphone and transmitter. External device, processor, wrongly given few books. ध्यान से लिखना है इसको. External device is PMT, processor, microphone, transmitter. 99% examiner is going to ask you internal device. Internal device is receiver stimulator. Clear? So internal device is made up of receiver stimulator. The external device is made up of processor, microphone, transmitter. Again, if you are going for AIMS, always remember 2 words: Mondini dysplasia, Mondini aplasia. Mondini dysplasia, Michael aplasia. Mondini dysplasia. What is Mondini dysplasia? 1.5 ton of cochlea. Mondini dysplasia is the most common indication. Michael aplasia is a contraindication. Always remember Mondini dysplasia. Mondini dysplasia is a most common indication. Michael aplasia is a contraindication. Brainstem implants are placed in lateral recess of fourth ventricle. Brainstem implants are kept in lateral recess of fourth ventricle. Clear? So these are the MCQs which we are expecting for your All India. Internal device of cochlear implant, receiver, stimulator, expected MCQ. Anybody, any student who can tell me this one? What is this one? Study the slide. What is this one? The given slide is for any student? Yes, Ludhiana students. What is this slide? Very good, sir. Merit, excellent. Baha, bone anchored hearing aid. This is a classical image of bone anchored hearing aid. Baha. Bone anchored hearing aid. Hearing aids we always place in external auditory canal. But bone anchored hearing aid we are placing on bone, on mastoid. So bone anchored hearing aid, what is the indication? Self-explanatory. Why you are keeping on the bone? Why you are keeping the hearing aid on the bone? We are keeping the hearing aid on the bone because we cannot keep in the canal. Why you cannot keep in the canal? Canal atresia, canal stenosis, and pus in the canal. So 3 indication of Baha, bone anchored hearing aid. The 3 indication are canal atresia, canal stenosis, and pus in the canal. Canal atresia, canal stenosis, and pus in the canal. Study the following slide. What is this one? Yes, everybody should reply. What is this slide? Yes, Patala students, what is this slide? This slide is a classical image of cochlear implant. This is your cochlear implant. Can you appreciate? External device, internal device, micro electrodes are there. So this is a classical image of your cochlear implant. One classification which was there in your last All India, Cotton-Mayer classification. What is Cotton-Mayer classification? Cotton-Mayer classification is used for laryngeal subglottic stenosis. So grade 1 stenosis between 0 to 50%. Grade 2 51 to 70%. Grade 3 71 to 99, and grade 4 is a complete obstruction. So Cotton-Mayer classification is used for laryngeal stenosis, grade 1 50%, grade 2 50 to 70, grade 3 99, grade 4 complete obstruction. Clear? That's it. Now concentrate on this slide. This is a classical slide for ciliatic keel. This is a plastic T-shape, small ciliatic keel is there. Concentrate. This is used after surgery. It is used after surgery. Jammu student, subglottic stenosis. This ciliatic keel is used after surgery of congenital webs. I will show you slide of congenital webs. So when there is a congenital web, there is a fibrous band in the larynx. If there is a fibrous band in the larynx, I dissect the band. When I dissect, later on, it can again adherent to each other. So we keep a ciliatic keel in between. So this is used after the surgery of congenital webs. Concentrate on this slide. This slide I just want to teach you. I want to show you a membrane, thyroid membrane. We are not going for any prof examination. I am going for All India examination, MCQs. As far thyroid membrane is concerned, examiner can ask you 2 MCQs. The first MCQ, which cystic swelling damage this membrane, perforate this membrane? Laryngocele rupture the thyroid membrane to become extrinsic. A laryngocele is a cystic swelling of the saccule in the larynx. If this laryngocele rupture the thyroid membrane, it will become extrinsic. The second MCQ, thyroid membrane is perforated by which normal nerve? Is perforated by superior laryngeal nerve. Can you appreciate? Can you appreciate this one? There is a small. Can you appreciate this one? This area is a opening. This area is a opening of superior laryngeal nerve. So thyroid membrane, two MCQs. One is your laryngocele and second is your superior laryngeal nerve. These are the three incision for, these are the, just draw the incision. These are the three incisions used for neck dissection. These are the three incision I am using for neck dissection. The first, which is T-shape. The T-shape incision is known as Scobinger incision. The second is known as McPhee and the last is known as hockey stick. Scobinger, McPhee and hockey stick. These are the three incisions for neck dissection. Clear? The three basic incision being used for neck dissections. Concentrate this slide. This is a slide for vocal polyp. This is a slide for vocal polyp. Always remember, vocal polyp is unilateral condition. What is the management of the given slide? What is the management of vocal polyp? Management of vocal polyp is surgical intervention, microlaryngeal excision. Polyp management is microlaryngeal excision. What is the most common site? Can you appreciate? The most common site is junction of anterior 1/3 and posterior 2/3. Junction of anterior 1/3 and posterior 2/3 is vocal polyp. This is a classical slide for vocal nodule. Vocal nodule always bilateral. Vocal nodule is always bilateral. Management is speech therapy. Management is speech therapy, voice rest. So management of vocal nodule is speech therapy, voice rest. Management of vocal nodule is surgery. This is a classical slide. This is a classical slide for thumb sign. Epiglottis inflamed. Thumb sign is a feature of epiglottitis. Is a feature of epiglottitis. Management of choice, IV antibiotics. Study the following image. What is the management of choice? IV antibiotics. Now, controversy, whether you have to go for H influenza or you have to go for streptococcus. This is the biggest controversy running in the market. You can say every student is asking whether H influenza or streptococcus. You can say in all international books, they have clearly mentioned streptococcus. But again, still, your DNB people, NB people, I will suggest you, I always criticize this type of teaching. But we are helpless. I will just give you a basic clue. If I would have been in your chair, I would go for H influenza in DNB in your All India examination. But if you're going for AIMS, you're going for PGI Chandigarh, go for streptococcus. Because these examiners, they are considering streptococcus as a most common. Clear? So this is again a gamble. It is better to play on H influenza in DNB examination. Jammu students, just 1 second here. I will show you. All these slides will be on your DAMS cloud. You can see the incision, name of the incision. Because considering the demand of time, just let me complete all these slides. This is a classical stipple sign. This is a classical stipple sign. Is a feature of laryngotracheobronchitis. Is a feature of croup, C-R-O-U-P. Croup is caused by parainfluenza virus type 1. croup is caused by para-influenza virus type 1. Expected MCQ. Examiner give you a history. 4-year-old child barking cough. On examination, this sign, they will show the slide. Last may they will ask you which of the following is a false statement. So in a patient of croup which is caused by para-influenza virus, will you prescribe antibiotics? Any role of antibiotics? No. Mainstay of treatment is not antibiotics, it is symptomatic treatment. Bronchodilators, analgesics, anti-allergic. So always remember, antibiotics is not the main treatment for patient of croup. This MCQ can be there. This is a classical slide for intubation granuloma. This slide is a classical slide for intubation granuloma. On the posterior commissure, on the posterior side of the larynx, posterior commissure, two possibility can be there. Either it can be ulcer or it can be granuloma. Ulcer will be a depression. Granuloma will be elevation. Management of choice. Study the following slide. What is the management of choice? Wait and watch. Conservative management. We will go for voice rest, antacid, anti-allergic. I will go for voice rest, antacid, anti-allergic. Clear? This is a classical omega sign. This is a classical omega sign. Feature of laryngomalacia. Feature of laryngomalacia. This is a classical image of congenital webs. Can you appreciate on your screen? A fibrous band is present between right and left vocal cord. A fibrous band is present between right and left vocal cord is a feature of congenital webs. Is a feature of congenital webs. This is not a important for your All India examination, just to show you the endoscopic image. Whenever we do the endoscopy of the larynx, we get this type of image. Subglottic stenosis. This is a slide for subglottic stenosis. What is the definition of subglottic stenosis? Any student? Diameter less than how many mm? Less than 4 mm. Just remember, diameter less than 4 mm is equal to subglottic stenosis. In which baby? In mature baby. In premature baby, the definition is 3 mm. Subglottic stenosis is less than 4 mm. In mature baby, it is less than 3 mm in premature baby. Clear? Study the following slide. Now this slide is a classical slide of leukoplakia. This is a classical slide for leukoplakia of the larynx, whitish patch on the vocal cord. What is the management? I taught you in the beginning. Management of leukoplakia. Wait and watch. We'll go for multiple biopsies. My concern is only it should not be converted to malignant. It should not show any malignant transformation. So I will go for multiple biopsies. Leukoplakia is a treatment of wait and watch is a treatment of choice. Now have this slide. This is a classical slide for papilloma. This is a classical slide for laryngeal papilloma. But only one papilloma is seen. Therefore, this is a feature of senile old age. This is senile papillomatosis. Only one papilloma is visible. But if you appreciate multiple papillomas, like this slide, if you appreciate multiple papillomas, it is juvenile. Senile, single. Always remember 3 basic points. Senile, always single papilloma. They never reoccur, never resolve. They never reoccur, they never resolve. Juvenile are multiple. They resolve spontaneously, they reoccur spontaneously. They reoccur spontaneously. Which virus is associated with papilloma? Human papilloma virus number 6 and 11. One-liner MCQ you can write. 6 and 11. 11 more than 6. Always remember which of the following is more virulent. 11 more virulent than 6. 11 more virulent than 6. Yes, South students, Belgaum students, what is the clinical significance of papillomatosis? Which procedure is contraindicated in papillomatosis? Which procedure is contraindicated in papillomatosis? Any student? In papillomatosis, we never go for intubation. Intubation is contraindicated. Papillomatosis patient having severe dyspnea, I cannot intubate because along with the endotracheal tube, the virus will go inside, seedling of the virus. So it is contraindicated. Intubation is contraindicated. Study the following slide. Very one of the best slide I always show in my lectures is a Blom-Singer tracheoesophageal processes. This is a classical slide for Blom-Singer tracheoesophageal processes. Is used after which surgery? Is used after laryngectomy. After total laryngectomy, we are using Blom-Singer tracheoesophageal prosthesis. 2 MCQs expected. Which is the best method of voice after surgery? Best method of voice is tracheoesophageal voice. Last DNB. Tracheoesophageal voice is the best voice after laryngectomy. Our forefather, they used to use esophageal speech. We use tracheoesophageal speech. Esophageal speech, they can ask you how many words patients speak out with the help of esophageal speech. 6 to 8 words. Esophageal speech, no, 6 to 8 words. Best speech is tracheoesophageal speech. Best speech is tracheoesophageal speech. Concentrate this slide. Now concentrate on this slide. Compare this slide with this slide. Compare this slide with this slide. In the first slide, in this slide, the incision is given on the anterior surface of sternocleidomastoid. Anterior surface of sternocleidomastoid is used for parapharyngeal abscess. The incision behind sternocleidomastoid is used for retropharyngeal abscess. Incision anterior to sternocleidomastoid is parapharyngeal abscess. Incision behind sternocleidomastoid is retropharyngeal abscess. Concentrate on this slide. Concentrate on this slide. Arrow. Focus your eyes on the arrow. This arrow is showing you which cell. I am showing you which cell on this slide. X-ray. Pune student, where you are getting teardrop sign? No, yeah, nothing to do with teardrop sign. It is a Heller sign. H-A-L-L-E-R. Heller sign. This is your Heller sign. Few MCQs. Mysore students wrong. Anodi is not. It is not Anodi. It is Heller. As far ethmoidal air cells are concerned, the few ethmoidal air cell you should write the basic formulas. Anodi cell is equal to posterior ethmoidal sinus is equal to optic nerve. Heller cell is equal to anterior ethmoidal sinus is equal to orbital floor. Agar-Nezzai, the most anterior cell is Agar-Nezzai cell. Agar-Nezzai is the most anterior air cell. The other name, controversial MCQ, this MCQ can be there. This is known as fourth turbinate. Agar-Nezzai cell is known as fourth turbinate. Is a part of anterior ethmoidal sinus. Is a part of anterior ethmoidal sinus. Bulla ethmoidalis is the largest air cell. Is a part of anterior ethmoidal sinus. So these 4 cells, they can pick one for your all India. Anodi, part of posterior ethmoid, optic nerve. Heller cell, part of anterior ethmoid, orbital floor. Hager-Nezai, the most anterior air cell. Fourth turbinate. Bulla ethmodalis is the largest air cell, part of anterior ethmoidal sinus. So I am just showing you the Heller cell. This is a classical Heller cell. Concentrate on this slide. Concentrate on this slide. These are the surface landmarking. Students, especially going for PGI Chandigarh, the 4 terms should be on your tips. Which 4 terms? Glabella, GL. So no need of concentrating on the slide. Just write what I am teaching you. What is glabella? Glabella is the most prominent part of the forehead. Glabella is the most prominent part of forehead. Glabella is the most prominent part of forehead. Uppermost part of the nose. Radix, R-A-D-I-X. Radix is the uppermost part of the nasal bone. R-A-D-I-X. The angle between glabella and radix. The angle between glabella and radix. Nasion. N-A-S-I-O-N. Nasion. What is nasion? Nasion is the angle between glabella and radix. So हमने 3 definition याद की. Glabella, the most prominent part of forehead. Uppermost part of nose. Radix. The angle between these two. Nasion. N-A-S-I-O-N. Now take your finger, keep on the bony cartilage junction. If you keep on the bony cartilage junction, that is known as rhinon. R-H-I-N-I-O-N. That is known as rhinon. That slide is, so we are having 4 important terms. Glabella, radix, nasion, rhinon. Most prominent part, glabella. Uppermost part of nose, radix. Angle between two, nasion. Bony cartilage junction, rhinon. This is a classical slide. Now concentrate on this slide. What impression you are getting? Bilateral swelling. So it is enteroconal polyp or ethmoidal polyp? Ethmoidal polyp, bilateral. But examiner is giving you the history. 10-year-old child with a history of trauma, with high-grade fever, with bilateral swelling. High-grade fever, trauma, with swelling. It cannot be polyp. It have to be infective pathology. So this is a classical image of septal abscess. Which MCQ will be there? Patient of septal abscess should be drained within how many hours? Within 48 hours. If you will not drain within 48 hours, this abscess, this pus will damage the septal cartilage. So always remember, septal abscess should be drained within 48 hours. Septal abscess should be drained within 48 hours. Any student who can tell me what is this one? Any student? What is this button-like structure? These are ciliatic buttons, small buttons used for, absolutely my student, absolutely right. Ciliatic buttons used for perforation. Septal buttons we are using for septal perforation. The MCQ. These buttons should be used if the size of the perforation is more than 2 centimeter. If the vertical dimension of the perforation in the nose, septal perforation, it is more than 2 centimeter, I will go for ciliatic button surgery. We will keep this small button. What is the most common cause of septal perforation? Surgery. Nasal surgery is the most common cause of septal perforation. Expected MCQ. Concentrate on this slide. This is a classical slide for Traumatic or non-traumatic CSF rhinorrhea? This is double ring sign. So double ring sign is a classical image of traumatic CSF rhinorrhea. Traumatic CSF rhinorrhea, it is double ring sign. Concentrate on this slide. This slide is a classical slide for anybody? Any student? Histopath slide given in the topic of nose. In ENT, in nose, only one topic is there. We discuss histopath finding. Rhinoscleroma. This is a feature of rhinoscleroma. Right side on your, right side, yeah. The slide you are getting is a crust formation. Crust formation in the nose. If there is a crust formation in the nose, two things should come in your mind. Either it can be atrophic rhinitis or it can be rhinoscleroma. Nasal crust with woody swelling. If the word woody is mentioned, always go in the favor of rhinoscleroma. On left side, histopath finding. Which are the hallmark feature of rhinoscleroma? Mikulicz cell and Russell bodies. Mikulicz cell and Russell bodies are the hallmark feature of rhinoscleroma. Can you appreciate? If you appreciate this slide, I have pointed two cells. Cell number 1, cell number 2. Cell number 1, everybody can appreciate this one. I feel everybody must be appreciating. Cell 1, cell 2. Cell 1 is a big cell. Cell 2 is a smaller one. Cell 1 big. The big is macrophage. Big is your macrophage cell. Mikulicz cell. The small one is eosinophil plasma body Russell cell. So always remember, in a patient of rhinoscleroma, if they show you a slide of big and small cell, always remember basic. I want 4 marks, hook and crook. Big cell is macrophage is equal to Mikulicz. Small is your Russell body. Concentrate this slide. I have often shown this slide in my class. This is your sarcoidosis. This is a classical image of strawberry appearance. Strawberry appearance of the nose. So strawberry appearance of the nose is a hallmark feature for sarcoidosis. Mulberry-like polyps, capital letters, mulberry-like polyps is a feature of rhinosporiosis. Mulberry-like polyps are the feature of rhinosporiosis. Mulberry-like nasal mucosa. Mulberry-like nasal mucosa is inferior turbinate hypertrophy. Inferior turbinate hypertrophy. Mulberry polyps, rhinosporiosis, mulberry mucosa, inferior turbinate hypertrophy. This is a classical slide. This is a slide for Ogren's classification, maxillary tumor, Ogren's classification. Line from the medial canthus, to the angle of mandible. Ogren's principle. What is Ogren's principle? Tumor below the line, good prognosis. Tumor above the line, poor prognosis. Tumor below the line, good prognosis. Tumor above the line, poor prognosis. This is your Leaf-Fort classification. Leaf-Fort classification. This is your Leaf-Fort classification. 5 MCQs should be on your tips. Leaf-Fort 1, can you appreciate? Below the maxillary, right? Fast. Low maxillary fracture. Low maxillary fracture is the other name of Leaf-Fort 1. Low maxillary fracture is the other name of Leaf-Fort 1. Leaf-Fort 1 का एक और नाम याद रखेंगे, floating palate fracture. Last DNB, floating palate fracture is a feature of Leaf-Fort 1. Any student can tell me the other name, third name of Leaf-Fort 1? Guerin fracture. Guerin. Guerin fracture is the other name of Leaf-Fort 1. Low maxillary, floating palate and Guerin fracture, Leaf-Fort 1. Pyramidal fracture, Leaf-Fort 2. Pyramidal fracture is equal to Leaf-Fort 2. Craniofacial disjunction. Craniofacial disjunction is a feature of 3. Craniofacial disjunction is a feature of 3. This is a very crucial slide for your All India AIMS examination. Concentrate on the slide. One is vertical fracture of the septum, one is horizontal fracture of the septum. Upper one is horizontal, lower one is vertical fracture of the septum. The horizontal fracture is type 2 fracture, Jarjaway fracture, class 2 fracture. What is the name of horizontal fracture? Class 2 fracture, that is Jarjaway fracture. Vertical fracture is the other name of class 1 fracture. Class 1 fracture, other name of Chevrolet fracture. Class 2 is equal to horizontal is equal to Jarjaway. Class 1 is equal to vertical is equal to Chevrolet. Second last slide, concentrate on this slide. This is a slide for lateral rhinotomy incision. This is a slide for lateral rhinotomy incision. Lateral rhinotomy incision is used for nasal pathology which is growing outside. Nasal pathology which is growing outside the nasal cavity is lateral rhinotomy. But concentrate on this slide, the last slide, Weber-Ferguson slide incision is used for maxillary pathology, So lateral rhinotomy is used for nasal going outside, and Weber-Ferguson incision is used for maxillary pathologies. Clear? Before completing next session will be, before starting the next session, you just write the classification. As far ENT is concerned, few classifications should be on your tips. The first classification, Ford classification, is for sulcus vocalis. Sulcus vocalis, the Ford classification. Ishika classification is used for thyroplasty. Wulston's classification is used for tympanoplasty. Cotton-Mayer classification is used for subglottic stenosis. Cohn's classification is used for congenital webs. Nelson classification is used for CSOM. She classification is used for Meniere's. Antony classification is used for acoustic neuroma. Fish classification is used for glomus tumors. Ogren's classification, Lederman classification, is used for maxillary sinus carcinoma. Ogren's or Lederman classification used for maxillary carcinoma. Lines of Sibylle is used for maxillary sinus carcinoma. Levinson criteria is used for malignant otitis externa or congenital cholestoma. Levinson criteria is used for malignant otitis externa or congenital cholestoma. Durlaki classification again used for congenital cholestoma. Clear? SADE classification, 99% MCQ will be there. SADE classification is used for retraction of part tensor. Retraction of part tensor. Last All India MCQ was there. SADE classification type 4, type grade 1, grade 2, grade 3, grade 4. Please write this classification. MCQ will be there. Retraction of part tensor, SADE classification. Tensor, part tensor, retracted, not touching incus, is grade 1. Retracted, touching incus is grade 2. Retracted, touching promontory but mobile is grade 3. Touching promontory but adherent to promontory, grade 4. SADE classification, retraction of part tensor, grade 1, grade 2, grade 3, grade 4. Not touching incus, touching promontory but mobile, touching promontory but adherent. Grade 3, what is the other name of grade 3? Atelectasis. Grade 4, adherent. Grade 3, atelectasis, complete collapse. Grade 4, adherent to promontory. It is adherent to promontory. TOS classification, retraction of par flaccida. Par flaccida, retraction of par flaccida is TOS classification. Grade 1, grade 2, grade 3, grade 4. Grade 1, retracted tensor flaccida, not touching malleus. Grade 2, touching malleus. Grade 3, retracted with mild damage to attic, damage. Grade 4, severe attic damage, So grade 1, not touching malleus. Grade 2, touching malleus. Grade 3, mild attic damage. Grade 4, severe attic damage. Copied? Last point. Few important scientists you should remember. The first important scientist, who is the father of modern otology? Father of modern otology. Anybody? This is Lempert, Lempert. Who is the father of neurootology? Last All India MCQ, neurootology is William House. Which scientist performed first appendectomy? The first appendectomy was performed by John Shee. Who gave the first traveling theory of sound? Traveling wave theory of sound. Von Baxi. Traveling wave theory of sound, Von Baxi. What is traveling wave theory of sound? Bass, high frequency, apex, low frequency. Apex of cochlea respond to low frequency, bass respond to high frequency. Clear? Here we will stop the ENT session. I hope you will be satisfied with all the MCQs. Try to revise these MCQs. Again, very best of luck. I'll suggest every student just to concentrate more on the class notes. The last 2-3 months are very, very crucial, are very important. Clear? So please just concentrate on the class notes. No need of touching any new book. No, this is not the time to touch any new book. Just concentrate on the class notes. Revise again and again. It will be a big advantage in the All India examination. Always remember, हमेशा याद रखो, if damn student cannot get rank, nobody can get rank in All India AIMS examination. So be confident. Our honest work, your honest hard work will give you a very decent rank in All India AIMS examination. Clear? Thanks a lot. Next session will be the radio session by Dr. Sumer. Clear?